Thank you for coming. I'm happy to introduce two speakers today. Our first speaker is Dr. Ehud Mendel, who is Executive Vice Chair and Professor of Neurosurgery here and Director of the Spine Oncology Program. He actually joined Yale recently in September of this year, where he came from the Wexner Medical Center at The Ohio State University and the James Cancer Hospital. He received his medical degree from Louisiana State University School of Medicine and further clinical training at the University of South Carolina and the University of Florida School of Medicine. And his team has pioneered new surgical techniques to reconstruct the spine following surgery to remove spinal tumors, including advancing minimally invasive neurological spinal surgery. So it's a great pleasure to welcome you to Yale and to your first grand rounds here.
Thank you. Well, I appreciate the opportunity to give this talk, and I want to thank all of you and Renee to make this arrangement for me. So I really wanted to talk about this topic that I've been very passionate about over many years, and that's the surgical management of patients with spine tumors. So let's see how to move this forward. Which year was it? Just click over there. Okay, so when we talk about patients with spine tumors, we're talking about two kinds of patients population. Patients who have primary spine tumors means the tumor is growing directly from the bone itself within the spine itself. These are primary bone tumors coming from the spine. The more common type of tumors are patients who have metastatic disease to the spine. And those are two very different patient populations, the primary tumor growing from within the bone of the spine versus the metastatic spine tumors. The goal is different, the adjuvant therapy is different, and the surgical options are very different. So the goal for primary tumors are really to try and cure the patient of the disease. The idea is to try and get this tumor out of there. It's the only site of disease, and the idea is to get the tumor out without interfering with the tumor capsule. So the idea is that if you take the tumor out in one piece without really breaking into the tumor itself, there is a potential of curing the patient of cancer. And sometimes even if it's not feasible, the idea is to at least give him long-term survival. When you're dealing with patients with metastatic disease, which is the most common issue, then you're really dealing more with palliation and quality of life. The adjuvant therapy is different for those two patient populations. There are multiple adjuvant therapy options for patients with metastatic disease. You can come stand up. And the primary ones, it's very limited. Surgical techniques are also very different to those two patient populations, and I'm going to talk about both of them. I'm going to talk first about the metastatic spine tumors because these are the most common patient population. So there is about 1.2 million new cancer cases per year in the United States, about more than 500,000 deaths per year. It's a major cause of death is complication due to metastatic disease. And if you look at this patient population, the skeletal system, the spine is the third most common site of disease after it spread to the lung and the liver. And the spinal column is the most common site of skeletal metastases. So this third patient population, the spine is the most common place for it to end up with. And as many as 90% of cancer patients will have spinal metastases at autopsy studies. And out of those 90%, 10 to 30% of these cancer patients will suffer from symptomatic spinal mets, so whether they have severe pain or whether they're presenting with significant neurological issues. The primary tumor, the other group that I've talked about, are very different patient population. These are very unique tumors. They're growing typically from the bone itself of the spine. And these are the osteodastiomas, the osteoblastoma, giant cell tumor, aneurysmal bone cysts, chordomas, chondrosarcomas, Ewing sarcomas, and the medical oncologists who deal with these type of patients are very familiar with these type of tumors. So when we think about surgeries on this patient population, we have to keep in mind what are these patient population that we're dealing with, especially the patients with a metastatic disease. They are typically immunocompromised. They have decreased white blood cell count. So they have high risk of post-op infection, high risk of bed infection. They have lack of fever response. They have lack of pleocytosis. There are sometimes issues where these patients get cement injection into broken vertebrae. Those can get easily infected, which turns out to be a big problem. Their nutritional status is not that great. They lose a lot of weight. They have increased catabolic state, decreased intake. Their serum albumin is low. And so you have to think about preoperative nutritional support. They are typically on steroids to supplement some of the agents that they are on, which obviously lead to a multitude of side effects related to the steroids that are listed over here. And for the sake of time, I'm not going to go over it. There are a lot of patients who are coagulopathic with thrombocytopenia. They may not be ambulatory, so they have increased for DVTs. So you have to think if you're doing surgeries on these patients, or sometimes if you don't, about DVT prophylaxis for these patients. And if you end up thinking about operating on these patients, some of these tumors are very vascular tumor, which means significant blood loss during the surgery itself. If you think about the primary bone tumor, you know, the aneurysmal bone cyst, the giant cell tumor, the hemangiopericytoma, these are known to be supervascular tumors. And as you get in there and you start removing this tumor out, you encounter significant blood loss. In essence, any tumor that has the word heme in it, you have to worry about a very vascular tumor during surgery. And these are just the primary tumors. If you talk about the metastatic patients, the renal cell carcinomas, the hepatocellular carcinoma, the thyroid, the pheochromocytomas are also highly vascular tumors, and you have to anticipate it as you're planning on getting these out. So in addition, when you're thinking about all those issues on this patient population, sometimes you have to think about wound closure. And the reason is because sometimes the tumors is large, which leaves significant defects. Sometimes there is a risk of just the increased age, the altered immune system, cachexia. Patients have been radiated, they are on chemotherapy, so the wounds don't heal as well. And so the likelihood of wound breakdown or infection is higher. And so these are all the issues that gets into, you know, when do you need to start thinking about the wound issues when it comes to wound closure. And so plastic surgery becomes to be a very good friend of us when it comes to ability to close this wound and minimize the post-op complication related to wound closure. And this is just some of the issues we're dealing with. Here is a patient with sarcoma, soft tissue tumor that's invaded all the tissues of the spine. So we can take this out, but clearly we need our plastic colleagues to be able to deal with these type of tumors. And as we remove them out, it's not just about how to remove it, but planning on once the tumor is removed, how to be able to close it. So these are, a lot of these cases it tends to be multidisciplinary in nature, with the ability to remove the tumor and then the ability to do some sort of flap to be able to close these wounds. Sometimes you're dealing with a very large tumors. This is a large sacral chordoma with big reconstruction. Again, got to rely and plan on plastic closure to close these wounds. So I wanted to go over some cases just to kind of give you the run-of-the-mill patients population that I, as a spine tumor person, deal with commonly. Let's just take these cases. And what's unique about the cases I'm going to show you is that they are all presenting the same. So these are patients who are presenting with back pain. Here is a patient with multiple myeloma. He's 57 years old, has some pain in the back, going to the legs, already get maximum pain medications. Biopsy revealed multiple myeloma, already underwent radiation, stem cell transplantation, still have progressive disease, and is neurologically intact. So this is very common in the multiple myeloma ward, where patients come in and they have back pain. And you can see right here, here's the MRI, and you can see there's a fracture of the vertebrae in the lumbar spine here. So there's a broken vertebra related to the multiple myeloma. And so we get called and say, can you do something here? What can you do? Here's a second case presenting the same way. Patient that come with back pain, has metastatic renal cell carcinoma. And you can see here, the MRI kind of look the same. There is a metastatic lesion here at L1. There's a little bit of a fracture here, maybe even a little fracture at T12 here. But the presentation is the same. The location of the tumor is in exactly the same place. The patient has no neurological deficit, just back pain. The only difference between those two cases is that the first case was multiple myeloma, the second case was a renal cell carcinoma. Are we going to treat it the same, or is the tumor biology dictate the treatment option? Here's a third case on a 52-year-old, again, neurologically intact, just having back pain, has a diagnosis of chondrosarcoma based on a CT-guided biopsy. And you can see right here another lumbar fracture. The first two cases were lumbar fracture, multiple myeloma, renal cell carcinoma. Here is a chondrosarcoma with a lumbar fracture right here at L4. We're presenting exactly the same with back pain. So should we treat that tumor the same way we're treating the multiple myeloma or the renal cell carcinoma? Here is a case, 68-year-old with thymic carcinoma coming in and received already radiation. And you can see right here at T11 and T12, there's lesions right here at those two vertebrae with maybe a little bit of a fracture right here. Again, thoracolumbar junction location is about the same, but a different type of cancer. So the question that we always asking ourselves, are all of these cases require surgery? Does the differences in the tumors or the tumor biology really makes a difference? And which approach should we take to treat and help these patient populations? And when it comes to my job as a surgeon dealing with these patients, these are the four options that I have. I can do what we call an intralesional resection, where we enter the tumor, we piecemeal the tumor out, we take the tumor out in piecemealing it. That's the intralesional component. We can do what we call an unblocked resection, where in one piece we take the tumor out without interrupting the tumor capsule. We don't necessarily have to do surgery. We can do just chemotherapy, immunotherapy, conventional radiation, or stereotactic radiosurgery. Or sometimes we can just inject cement into the vertebrae just to restore some mechanical stability, which is minimally invasive. So I wanted to show you some specific cases because the four cases that I showed were all presented with a non-neurological deficit, which always increase the level of concern. But when they do have a neurological deficit, then things becomes even more urgent as to what can be done. Here is a 23-year-old patient who comes in, stood up, complaining of some weakness. And when you look at the exam shows a little bit of weakness in her legs, 4 out of 5 strengths in both of her legs. And here is an MRI which showed T9 broken. There is severe tumor compressing the back of the spinal canal, pressing the spinal cord. And unfortunately here, she's in the emergency room and there's no diagnosis. We do not know what this looks like a tumor, but she presented to the emergency room and this is what the MRI looks like. And the question is what to do, and that's where we get called. Then the unfortunate thing here is that unlike the first 4 cases where we knew the diagnosis, which can help us dictate what to do, here we are faced with a situation where the patient presenting with cord compression, with mild weakness in the legs, but no diagnosis. And so here is some of the views. You can see on the axial cut, severe cord compression, the port is squashed. There's a lot of tumor around the vertebral body, but the patient has a very minimal weakness in her legs. And so this patient, here is the CAT scan, shows mild compression fracture there at T9. A neurosurgical consultation was requested. And the question is, should the patient be taken emergently to the operating room because there is a little bit of weakness in the legs, but no diagnosis, we don't know what it is, or wait on the surgery, trying to establish a diagnosis, and based on the diagnosis, make a decision of what to do. And so on this case, the patient, the recommendation by the neurosurgeon on call was to take the patient to surgery and do a decompression. And so a laminectomy was done. And you can see right here, the back of the spine is removed. The canal has been opened up. You can see right here on the postoperative MRI that the spinal cord looks a little bit better. There's not much compression there. But if you look at the axial cut, the majority of the tumor is left behind. The entire vertebral body is encased in tumor, and all of that was not touched by the purpose of the surgery was really to just take the portion within the canal that's pressing on the spinal cord. The postoperative specimen came back to be lymphoma. And so the question was that the right choice for the patient, considering lymphoma being a highly radiosensitive tumor, highly responding to adjuvant therapy, and rarely actually needs any surgery, was there the right choice for the patient? And one of the downsides is now the patient needs to recover from the surgery. There's a fresh wound that will not tolerate radiation so quickly. So there's some downside for doing the surgery and now have to wait for the treatment. Now, let's say we take the same case, but instead of 4 out of 5 weakness, the patient only had 2 out of 5 weakness. And would that have made a difference when it comes to taking the patient to surgery? So how much of a weakness is acceptable and how much of a weakness is not acceptable? That becomes a very difficult question to decide whether to take the patient to surgery or not. Here is another patient with a 51-year-old who comes in with weakness and some incontinence. And you can see there is a tumor in the sacrum. There's a lot of tumor in the canal, pressing on the spinal canal, explaining the incontinence and some of the weakness. And you can see another MRI here shows the finding of a broken sacrum, some tumor in the canal. And the patient underwent an emergent surgical intervention with a laminectomy and fixation. But unfortunately, this turns out to be a primary bone tumor with a chondrosarcoma. And when they found out it was a chondrosarcoma, the patient underwent stereotactic radiosurgery. Unfortunately, this is one of those tumors where the recommendation is to try and do an en bloc resection. Once you enter this tumor and you take it in piecemeal version, then there is a 100% chance of recurrence. So really, the only chance of the cure for this patient would have been during the first surgery with attempt to remove it in one piece without entering it. Unfortunately, here, the patient may have done well with the decompression, but the tumor have entered, and that leads to spillage in the surrounding, which ultimately will lead 100% to recurrence. And sure enough, this patient came back 3 years later and presented with this little bump in the back that thought was maybe one of the screws are getting loose. But when you look at the MRI, you see that the entire tumor is now recurring. And in fact, that bump is actually a metastatic disease underneath the skin, which was expected considering that the surgery that was done was unfortunately intralesional instead of an en bloc resection. And not only that, now the rod is broken, and then ended up taking this patient back to surgery. We removed the lesion itself in an en bloc fashion, but it really makes no difference now since the tumor has spread. And here's a specimen revising the cancer here, and the plastic surgeons came by and did a flap to close this wound. So the take-home message, the message in all this is that this could be a mismanagement in a way of trying to think through the process of what to do here. And it could be related to bad timing operations, or sometimes operation with no diagnosis where you don't really know what to do. And so I call it a triple W phenomena, to be aware of the triple W of the wrong operation on the wrong patient, sometimes by the wrong surgeon who emphasizing neurological issues versus oncological issues. So when you're dealing with this type of tumors, and I'm going to go a little fast just for the sake of time, I mentioned some of these issues here when it comes to the goal. And a lot of these things has to be done with making the right diagnosis and know what it is that you're dealing with. Biopsy is extremely critical as much as possible. Anytime you have a chance, you have an option of doing a biopsy, make sure that you do the biopsy up front. Here is a patient that supposedly thought that he has a chondrosarcoma or a chordoma, was scheduled to surgery. A biopsy was done, and it turned out that this was an ependymoma, which was a completely different tumor, required completely different surgery. So biopsies are very critical. Make sure on these particular cases that you avoid a transoral or a transrectal biopsies, because if the idea is to take the entire piece of tumor out, the tract itself can lead to contamination. And so we typically mark where the tract of the biopsy is being done, and then we'll remove the entire specimen with the tract itself to make sure that the whole specimen is being removed in one piece. And you can see right here some of the cases where the place where the skin was violated with a biopsy is being removed with the specimen itself, which means that the biopsy needs to be very close to the midline. Stay away from this type of issues where the biopsy is done very far, way out to the side, where we are unable to remove the tract itself with the specimen. The biopsy needs to be very close to the midline. I mentioned some of these intralesional options, en bloc options. These are really the surgical options that we have. The intralesionals, as I mentioned, are piecemeals. Here's a patient with 2-level metastatic disease at T3 and T4. We as surgeons need to be comfortable with being able to approach the spine from any direction possible. whether through the front, through the side, through the back. Here is a case where the spinal cord is being suspended, the nerve roots has been ligated, and you can see that gives us access to the anterior vertebral spine through the vertebrae. We can then put the screws in our place, and then we can actually remove the vertebral bodies through the back and then get underneath the spinal cord and sneak a cage to replace the broken vertebrae. And that's what it looks like after the surgeries. The unblocked resections, where we're going in around the tumors, are much more complicated. Here is what we actually want to achieve, where the entire segment of the spine is being removed in one piece without interrupting it. And that takes a lot of planning when it comes to where to make the cuts, ultimately to be able to remove the specimen in one piece. And you can see in this picture again, the tumor has not been violated on a primary bone tumor. And you can see right here how the entire segment of the vertebra is able to be removed from around the spinal cord without interruption. Radiation obviously is a huge component to what we do. There is a conventional option, just radiation. There is a surgery followed by radiation. And then here at Smilo and in major cancer hospital, we have the option of spinal radiosurgery. We've written about, there's a lot of cases out there about radiotherapy and radiation treatment option for patients with metastatic disease and what are the indications for this thing. Recently, we just published our series when I was at the James Cancer Hospital, but postoperative stereotactic body radiotherapy for spinal metastasis and predictor of local control. And it's an amazing tool to supplement our, our intervention and maintaining control of these tumors. So, the data is very promising. This is some of the cases. You can see these are cases that don't need surgery, single met. Here is a tumor with a recurrence around the vertebral artery. And so really, this is a totally non-invasive alternative or adjuvant treatment to surgery. Cement injections, a lot of you mentioned this patient knows that this is a very good tool for patients with mild fractures who needs to continue going with treatment, who cannot go through major surgeries. So either you do vertebroplasties or you can do kyphoplasties where we put a balloon in, you can inflate the balloon to correct some of the deformity, remove the balloon, and then inject cement into the bone vertebrae. There are lots of papers that we have been looked at to show that these treatments of cement injections are an amazing, not just diagnostic, but also therapeutic indications for patients with spine tumors. Sometimes we can't do it. If there's a lot of fracture, bad fracture, sometimes the bone is already in the canal. The idea is to make sure that cement doesn't leak into the canal and press the spinal cord and lead to neurological issues. Or sometimes you can see right here where the tumor eats through the back of the bone and eats right through it. So there are some contraindications of when not to do it. This is what we don't want to see happen, where cement leak into the spinal canal. Or right here where you can see a lot of cement was injected and cement is kind of overlying the entire thecal sac here. Sometimes you see cement in other places, even in the brain, you can see particle of cement going to. Here is a case where you don't want to see again, where cement was injected and a lot of the cement leaked into the canal, leading to a patient presenting right after the surgery with neurological deficit. So you got to watch for those things. Here is a patient who have a lesion in the odontoid, and we used to treat these with significant reconstruction of the cervical spine to help with mechanical neck pain. But now if you really push the limits, cement is a huge tool. And on these cases, now we're getting to the point where we don't need to do big surgeries. We can actually go through the back of the mouth and inject cement directly into the odontoid. And you can see what it looks like after the surgery. And we actually published this technique where we can use the stereotactic CT guided images and fluoroscopy and able to go to the back of the mouth with our ENT colleagues and able to inject the cement right into the broken vertebra instead of putting the patient through some sort of an occipital cervical fixation. So some of those contraindications, we can refute them. And we actually publish our series at MD Anderson when it comes to when to do it and when not to do it. And the conclusion was that relative contraindications can be relaxed for patients without other options with no clinically significant increase in complications. So I want to, for the sake of time, just go quickly through my last slides here. The key, if you want to take one slide out of all this, is that this is when we're thinking about surgery. We're thinking doing surgery for patient when we think that we can make a difference, that we can alter the prognosis. We think about doing surgery when there is significant spinal instability. The spine is so broken that the patient is unable to get out of bed. We're thinking to do surgery when there is a neurological deficit. And pain by itself, even without deficits, is also an indication for surgery. And so spinal instability, clearly, if you look at this MRI, you can see that the spine is broken. This is something we can fix with surgery. And there are now a scale that helps us that we have developed to define what is spinal instability in patients with metastatic disease. And I'm not going to take you through it, but it's a very nice SIN score that you can add all these numbers. And if you add all these numbers, when it comes to location, pain, the type of lesion it is there alignment or no, how much of the body is involved, you can add all of these points, and that will lead to deciding whether the patient is stable and unstable, which may help deciding whether to do surgery or not. Neurological deficits is clearly something that we get called on, and then we have to make a decision as to whether to go on with surgery or not. And as I mentioned, just pain sometimes also helps us, helps with surgery, especially when we're dealing with the mechanical type pain symptomatology, which indicate a fracture. When you're thinking about surgery, just always make sure that it's physically, technically feasible to do, adequate approach, good strategy, satisfactory reconstruction, and that ultimately it's going to give a durable patient benefits, because ultimately these can end up to be a very large lesion for these patients. So I just want to get to the last part, and that is the primary tumors. These are not a metastatic disease. These are the most challenging cases. Some of them can be treated with adjuvant therapy, but most, the chondrosarcoma and the chordoma, cannot. And some of them can respond to preoperative chemotherapy, but most don't. The good example, for example, is denosumab, which helps very much in patients with giant cell tumor. We used to think that all of these patients need surgery, but you can see they present with big holes in the vertebrae. But on denosumab, here is a patient with an L3 fracture. You can see on the CAT scan, there is no L3. It's completely eaten away by the tumor. And you can see the PET scan over here. Here is the CT reconstruction of this L3 lesion, very large lesion. But you can see that with denosumab, the vertebra becomes very calcified and strong to the point that there may not be a role for surgery anymore for this patient population. Here is a pharmacist. Again, the odontoid, the C2 vertebra is completely eaten away. There's almost nothing left of the C2 vertebrae. All we did here is we stabilized the spine. We did not take the tumor out. You can see right here, there's posterior stabilization. And within a couple of months, the entire bone filled in here, and there's no more hole that was there before. So there is definitely a clear role for adjuvant therapy. Now, why these unblocked resections? Because that's really the only way to give a chance for these patients. And here is a patient with a sacral tumor that we can go in, we can ligate the thecal sac, and in an unblocked fashion, you can see the margins are clean all the way around it. And we know from all the data that's out there that unblocked resection can lead to cure of these patients. Here's a patient with sarcoma in the mid-thoracic spine. We don't want to enter this tumor. We want to be able to remove this tumor out in one piece. We'll plan where we're going to make our counts to deliver this vertebrae from around the spinal cord, and ultimately able to remove the entire vertebrae in one piece without entering it, and able to then reconstruct it and give the patient a chance for cure of patient. The sacral tumors are the biggest ones to deal with and are the most complicated one. There are lots of methodologies, and I'm showing some slides here about how we approach these tumors. There are lots of techniques that I'm not going to get into. That's more surgery-oriented talk about how to be able to remove a lot of these sacral tumor and ultimately able to achieve an unblocked resection on these tumors. Some of these techniques we have described. Here is some big example of a chondrosarcoma that's going up to the lumbar spine, up to the pelvis. This is obviously combined with multidisciplinary approach, where an unblocked resection was performed with orthopedics and urology and plastic surgery, and this tumor was removed with vascularized bone graft. We published this technical aspect of using autologous bone graft, and then the reconstruction obviously was a significant issue about how to reconstruct these tumors when it comes to be able to do this type of surgeries. These are these are big time surgeries. This is one of the surgeries that we have done that ended up being the front cover of the Journal of Neurosurgery. These are highly complex type surgeries when it comes to do them. You can see intraoperative pictures of the vascular graft that has been used on these particular patients. And these patients ultimately fuses very well. This is the postoperative picture of the patient a year later. So there are some frontiers that have been looked at when it comes to getting engineering involved with personalized model, 3D printers, try to predict which vertebrae are going to break. We're looking at animal models and unblocked tissue characterization. We're aiming toward personalized surgeries on these patients, take the patient's CAT scan, the patient MRI, creating these 3D reconstruction models for these patients, creating those models, and then ultimately figuring out, this is some of the 3D models that we have done on the lady with breast cancer, and figuring out what type of surgeries would benefit these patients the most. And then you can see some of the implants, some of the 3D implants, vertebrae that can be patient specific. For the patient, you can see half a sacrum, patient specific for these particular patients. We're looking at different modelings to reconstruct the spine. Again, these are all specifically for the patients itself. So it's just some of the slides that we are doing right now. So in conclusion, the management is challenging. It can restore and protect neurological function. It can improve pain. It can impact the quality of the patient's life. Understanding the biology of these tumors is critical in defining the goal of treatment in a given patient and determining the most appropriate therapeutic options. Surgeons dealing with this neoplasm really should be familiar with all surgical approaches, as well as complex anterior-posterior reconstruction techniques in order to provide optimal care for these patients. So overall, I want to end up by saying, don't try to be God. Thank you.
Okay, thank you very much for a really fascinating talk and what a challenging field. Unfortunately, since we're running late, we won't have time for questions. I know there are some, so please direct your questions directly to Dr. Mendel, but we do have a second speaker today. Thank you very much.
Thank you.
So our second speaker today is Henry Park, and you can maybe get your slides up. Henry is an assistant professor of therapeutic radiology here and chief of thoracic radiotherapy. He received his undergraduate medical degrees from Yale and completed internal medicine training at the Harvard system, and then returned to Yale for radiation oncology. He specializes in radiation therapy for lung cancer and head and neck cancer and brain tumors, and is also quite active in comparative effectiveness in health services research, as well as serving as our program director, residency director in therapeutic radiology. So Henry, the floor is yours.
Okay, thank you very much for the very kind introduction. So today I'll be speaking about new directions in lung SBRT. So here are my disclosures. So my goals today are to discuss updated evidence on the role of SBRT in early stage non-small cell lung cancer, as well as lung oligometastatic disease. I'll also be reviewing our lung cancer clinical trials that involve lung SBRT that we've had open here at Yale. So first, we'll start with early stage non-small cell medically inoperable patients. So if here we have an elderly patient with a lung nodule that's deemed medically inoperable due to because of the patient's poor pulmonary status, how do we treat? So really, it's all about the real estate mantra. It's about location, location, location for how we end up treating this. So SBRT dose fractionation, just to kind of walk you through a few terms here, when we talk about conventionally fractionated radiation, we talk about a low dose per fraction, about 2 gray per day over many fractions, usually about 30 to 35 fractions over 6 to 7 weeks. Hypofractionated radiation is a moderate dose per fraction, about 3 to 7 gray per day over a fewer number of fractions, about 8 to 20. An SBRT would be a high dose per fraction, so usually 10 to 18, but really up to even 34 gray over a very few number of fractions, which is defined in the US as 1 to 5 fractions. I'll also talk about this concept called biologically effective dose, or BED. This BED increases with a higher dose per fraction and actually increases with a lower number of fractions. So 54 gray in 3 fractions is actually higher in BED than 60 gray in 5 fractions. And that is higher than 60 gray in 15 fractions, which is afterwards higher than 60 gray in 30 fractions. So, and for tumors that are outside what's called this no-fly zone, we call this the no-fly zone, which is within 2 centimeters of proximal tracheobronchial tree. Anything that's peripheral to that or outside of it can be treated usually with a high-dose 3-fraction regimen. So we know from the Chisel trial that SBRT is superior to conventionally fractionated radiation for stage 1 non-small cell lung cancers like this. But we know that if you're treating within the central region of this area, then the toxicity can be too high. Whereas when you treat outside of it, the outcomes have been excellent. 98% control at 3 years and 90% control at 5 years. So we did some work here as well as some other places where we looked at for central tumors, how do we proceed with SBRT here? So this is a program that was started by Roy Decker several years ago, and really to decrease the dose, but also extend fractionation to 5 sessions. Looking at our Yale retrospective data, we found that overall survival, local control, and toxicity were similar between central and peripheral tumors. This has been followed up with an R2G0813 trial, phase 1 and 2 study that was using dose escalation with 5 fractions to see that really all their doses that they were using, this was safe and effective for central tumors. So we have a trial here that I've been working on with Dr. Peters for the last several years. This is a dose de-escalated 3-fraction regimen. We call this DD3. This is for central but not ultracentral lung tumors, so either primary non-small cell lung cancers or metastases. That uses a similar BED to current 5-fraction regimens, but lower than current 3-fraction regimens to be more convenient for our patients, given that we're not necessarily sure that dose de-escalation as well as extending fractionation is really essential in this case. So we're looking at a lower dose 3-fraction regimen instead for these central tumors. We define this as being within 2 centimeters, but not abutting the esophagus, heart, or the tracheobronchial tree. It's a phase 1 and 2 study. We're targeting 60 patients in total over a course of 5 years. We had this open for the past year and have recruited about 13 patients. So we're pretty much on target here. Our primary endpoints are grade 3+ toxicity as well as local control. So for ultracentral tumors where they're either abutting or within 1 centimeter of critical central structures, do we avoid SBRT altogether and use a more fractionated regimen? So the HIGHLIST trial here just got published this year that looked at high-dose 8-fraction regimens with a similar BED to the current 5-fraction regimen, and found actually the closer you get to the main stem bronchi or the trachea, the higher likelihood of fatal toxicity. So it's a very serious, the toxicities in general, but actually even having grade 5 toxicity was up to even the 30 to 40% range when you get that close to the main stem bronchi or trachea. Much lower risk if you're near lobar bronchus instead. So these are things that are very concerning to us with using these very high doses in ultracentral tumors. So what do we do instead when they're not candidates for SBRT based on either tumor size or based on location, like we talked about? We've been doing some work with some medical students here, Nadia Saeed and Alex Sassi on using the National Cancer Database, with retrospective studies showing that there was higher survival among stage 1 non-small cell lung cancer patients who are receiving hypofractionated radiation compared to conventionally fractionated radiation, especially when using a higher BED. We also are looking at our Yale databases as well, comparing a lower dose 15-fraction regimen to a higher dose 18-fraction regimen to those who are not candidates for SBRT. And we hope that one day we can maybe compare this winner to an SBRT regimen for those who are maybe a lower dose SBRT regimen to see what works best for these ultracentral tumors. On a different topic here, for multiple targets, if we have multiple non-small cell lung cancers, which we sometimes do encounter, can they be treated simultaneously with SBRT? So this is work that we just published this past week that we looked at our own data here among 60 patients treated over the last 12 years to 126 lesions, and found 87% local control and 70% overall survival at the 2-year mark with acceptable toxicity. 23% grade 2 toxicity, and only 3% grade 3 plus toxicity. Both of those cases, we would have used a different regimen these days. Those were both treated a long time ago. So now moving on to SBRT plus systemic therapy. So we know from the surgical literature, including some work that was done here from Dan Baffa and his group, that patients who undergo surgery may benefit from chemotherapy, and even more recent trials showing that immunotherapy may help in selected patients as well. So can SBRT patients also benefit from systemic therapy as well? We looked at our data here that showed that patients who received SBRT and systemic therapy, did have a lower risk of regional distant failure. But we also do know that chemotherapy is challenging in this often frail SBRT population, which has garnered a lot of interest in using immunotherapy instead. So can we use immune checkpoint inhibitors? One study, we have two studies open here at Yale that are looking at this question. One is the Keynote 867 trial, which is a phase 3 study targeting 500 patients. This would look at SBRT plus concurrent and adjuvant pembrolizumab versus for stage 1 to 2 non-small cell lung cancer. This has been open in New Haven and North Haven only at this point, but this would be a Q3 week infusion either way, whether you get the immunotherapy or placebo, with the endpoints being event-free survival and overall survival. We also are about ready to activate this new study, SWOG S1914, which has been activated nationally, but ready to open here at all of our care centers. So it's a phase 3 that's targeting 480 patients. Similar question, but slightly different. SBRT plus minus neoadjuvant concurrent and adjuvant therapy, which will be, in this case, a different immune therapy, which would be atezolizumab, and only for 6 months instead of 12. Big difference is that you just get the SBRT. And then there's only including high risk factors, which are size greater than 2 centimeters, SUV max of 6.2, or a grade of 2 to 3 on biopsy. And again, this will be open in all care centers that have Yale radiation. So moving on to early stage non-small cell lung cancer medically operable patients. So can SBRT be an alternative to surgery for medically operable patients? First was work from James Yu and Carrie Gross looking at SEER Medicare, looking at a retrospective study here that found that overall survival was improved for patients who received surgery versus those who received SBRT. The short-term toxicity did seem to favor SBRT, but did even out by about 2 years out. In the National Cancer Database from Dan Baffa's group found that overall survival was higher among those who got surgery than those who got SBRT, even after adjusting for known confounders, including selecting for only patients who had refused surgery, but were recommended surgery, or those who had no comorbidities or had a low comorbidity score. However, we know that selection and indication bias is a concern when comparing surgery and SBRT retrospectively. There's work out of here as well as other places showing that patients who are considered operable, who do receive SBRT, do have higher overall survival and progression-free survival compared to those who are inoperable. So it's difficult to compare these patients to consider them to be an apples to apples comparison, even though they do have similar local control and regional distant failure as well among operable versus inoperable SBRT patients. So Frank Dedebek has led this this 4-part review here that I've drawn a few figures from. One thing he was showing here is that randomized phase 3 trials of surgery versus SBRT are ongoing, but have been historically difficult to accrue to. These 4 here have accrued a total of 2.9% of their targets. So really, they all have to close being very underpowered. There's the Valor study of the VA that is probably the most promising ongoing trial. So far has accrued more than all of these have combined so far. Yet this is targeting 670 patients and is not due to read out for at least 5 years. So in the meantime, what do we do? We know that the STARS and Roselle trials have been actually merged together and pooled in an analysis. Again, both underpowered and closed early due to poor accrual. They did find that in this case, a surprising result that SBRT patients actually had higher overall survival in this population, which was a very small population again, but it was similar in recurrence-free survival. A larger study was done more recently, a non-randomized study, so single-arm SBRT trial that had better accrual, but from MD Anderson that looked at that actually had a protocol-specified comparison to an institutional surgical cohort, and found that SBRT outcomes in this population was similar to surgery in overall survival, progression-free survival, and other outcomes. And again, surprising results that 87% overall survival at 5 years for SBRT. So hard to know how to extrapolate some of the older studies that included patients who were not great surgical candidates, especially in terms of overall survival. So at the end, with Frank Dedebek and several members who are here right now is at Yale, from different disciplines, we all got together and has been working on this 4-part Yale guideline. That's a collaboration that tries to form this practical framework for weighing short-term versus long-term benefits and downsides. This is one of many figures in this paper that are looking at how can we go through all the data that's out there right now, as imperfect as it is, and try to figure out which patients may benefit from SBRT, lobectomy, sublobar resection, or ablation. And as you can see in this figure, there's nuances with and patient selection that's really critical. And I was very proud of how well our team has worked at Tumor Board, as well as just on the phone otherwise, working through these, working through the decisions about how to handle each individual patient. So moving on to lung oligometastatic disease. So here we think of oligometastatic disease as an intermediate state between local and systemic disease, where the kind of original Hellman and Wexelbaum definition was that there may be a small subset for whom radical local treatment of primary cancer and all metastatic lesions might have a curative potential, often defined as 1 to 3 or 1 to 5 lesions. So we know that surgery or radiation may have a larger role in localized disease, with systemic therapy having a much smaller role. In widely metastatic disease, it's really the opposite, where systemic therapy is a primary role over surgery and radiation. But in oligometastatic disease, there may be a role for both. Here, this is some going through some papers here that some trials that are phase 2, looking at local consolidative therapy. In this case, the Gomez study from MD Anderson showed that either surgery or SBRT for stage 4 non-small cell lung cancer patients with 1 to 3 metastases and no progression after 3+ months of chemo actually had increased progression-free survival and overall survival, median of 41 versus 17 months, compared to not using local consolidative therapy and using systemic therapy alone after this point. This was also shown, this was a study just of SBRT, but similar population, stage 4 non-small cell lung cancer from UT Southwestern after 3+ months of chemotherapy. This had to be stopped early because of a very clear progression-free survival improvement. So this was shut down by the IRB because it's thought not to be ethical to continue this study. And then Saber Comet looked at the oligometastatic cancers of any primary and found 5-year overall survival of 42% versus 18%. So actually quite similar to what the Gomez study showed. The treatment-related deaths were 4.5% in this case, so they did have 3 deaths in this population, but there was no quality of life difference among the rest. So there's always caution, of course, that needs to be taken when you do this. All of those are in the chemotherapy alone era. Now we're in the immunotherapy era as well. So the NRG-LU002 is the current ongoing phase 3 study that's looking at a similar population, but now allowing for immunotherapy in their most recent amendment. So I think still quite relevant question to ask at this point. They do require that you use SBRT for at least 1 lesion, but can use surgery for other lesions as well. So now for lung oligoprogressive disease, this is a somewhat different concept in that you may not necessarily have just a few mets up front. You may have several sites of disease and have good control with systemic therapy. But when you stay on that systemic therapy or when you're off of it, if one or a few areas grow, then you're faced with choices. Do you switch therapy? Do you continue therapy? Or do you add therapy? And so this is some work out from Scott Gettinger, looking at SBRT for oligoprogressive non-small cell lung cancer after immunotherapy. A small study of 26 patients who had acquired resistance to immune checkpoint inhibitors. 15 of them had local therapy without immediate salvage systemic therapy. So they either were on a treatment holiday systemically or just remain on their same immunotherapy. It's a somewhat busy figure here, but in essence, the green is where they were able to, the circles are where you got local therapy. The green is when they were able to stay on immunotherapy, and then gray is when they had to switch to something else. 2-year overall survival was 92%, and quite a few patients were able to maintain immune checkpoint inhibitors for years, in some cases after local therapy. So this is a study from Roy Decker and Allison Campbell, an investigator-initiated trial here that looked at SBRT for oligoprogressive non-small cell lung cancer after immunotherapy as well. This was a 21-patient phase 1-2 study where you gave pembro until progression, then SBRT, and then restarted pembro again right afterwards. The endpoint was overall response rate in non-irradiated lesions to investigate, can you reinvigorate this immune response and maybe even get an abscopal response to sites that were not treated. Disease control overall was 57%, but interestingly, there were 2 patients, the 10% of the group that had a partial response for more than a year. And there's lots of ongoing studies now investigating more about who those, the factors that may have led to that for those patients. Just at Astro last month was presented this CURB study out of MSK that looked at a similar population of non-small cell lung cancer patients or breast cancer patients, and interestingly found a large PFS benefit for SBRT for non-small cell lung cancer patients, but not for breast cancer patients. You can see in lung 44 versus 9 weeks, whereas breast was 18 versus 19 weeks, so no difference there. Paper still yet to come out, so I think there's still a lot of questions here, but this is intriguing data that maybe this may be histology independent in terms of the role of SBRT in this context. So Dr. Johung is about to activate this study as well for renal cell carcinoma. So this is a phase 2 study where we're looking at ICI until disease progression, and then SBRT, and then ICI again, with the endpoint being progression-free survival. There's a lot going on in this arena. Just again, for this DD3 study, we do include oligometastases, oligoprogressive disease as well for this tumors that are central. So we've had this review here that we wrote last year on local ablative therapies. If you want more details, feel free to refer to this on other studies that have come out as well. So in summary, we for early stage non-small cell lung cancer, our future directions here are that we're really looking to optimize patient selection and SBRT dose fractionation for peripheral tumors, for central tumors. We have this DD3 trial, like I mentioned, as well as ultracentral tumors, which we're currently investigating retrospectively and hopefully leading to a prospective study at some point. We're looking to add immunotherapy to SBRT and seeing to investigate whether that is helpful or not and which populations it may be useful for. 2 ongoing trials open at Yale as well, the Keynote and the SWOG studies. Oligometastatic and oligoprogressive disease, optimizing patient selection and dose fractionation as well as sequencing, combining SBRT with ICI. So we have some
just make sure that
and prospective studies, trials.
Pure credit, that's his name.
Going forward. So outside the scope today, we have a lot of exciting ongoing pending trials and pending trials in the Yale lung DART as well as the TRAD DART. I'm not going to get into this today, but locally advanced non-small cell lung cancer, limited stage and extensive stage small cell lung cancers. There's a lot going on. So we're excited to be working on that. And finally, I'd like to acknowledge our Yale Thoracic Radiotherapy program. The members of our team have been phenomenal. We've been working weekly on chart rounds ever since I've had the honor of taking this over this program in 2019 from Roy Decker, who's been just an amazing mentor of mine, and who really started the SBRT program here at Yale several years ago. And among our 6 sites, we go over all our radiation plans having to do with lung cancer every week to be sure we're improving communication and quality assurance and standardizing practice and sharing information. So I'm just very blessed to work with this wonderful team. Thank you all very much for your time today.
Thank you, Henry. Some very impressive results on some of the trials you showed us. Are there questions? I see someone has a hand up, but I can't see who that is. Or are there questions in the chat? No questions? So Henry, in your time here, what do you think has been the biggest step advance in radiotherapy?
SBRT specifically, I think our ability to really use the imaging that we have and be able to target even more precisely over time. And I think we're excited to have a new reflection machine that's coming in soon to be able to target oligometastases and oligoprogressive disease. I think that's really the future here in terms of using local therapy to supplement the excellent advances we've made in systemic therapy that has just been so impressive, and especially in lung cancer, where we see just so much better survival than we've ever seen before for stage 4 patients. And combining this with targeted agents and immunotherapy and chemotherapy to really extend survival. And are we going to see, we're seeing more patients at 10-year mark now, even more who are still disease free. So, it's a very exciting time that, as the technology improves and our ability to select patients properly for this improves, we're hoping to, really see more and more patients benefit from using SBRT in this setting.
Terrific. We have Dr. D, do you have a question? I see a hand. Maybe not. Okay, well, thank both speakers again. It was a terrific series and I learned a lot, and I hope the audience did also. Thank you.
Thank you.